also from the University Medical Center in Groningen. She has been working in the healthcare sector in many different ways, I guess, for quite some time, but is now in the Department of Epidemiology, Biostatistics, and Health Technology
Assessment.
So the Department of Epidemiology is actually quite large, with a number of subdivisions that seems to, in my mind, go through a lot of reorganization every time. But Karin really has a lot of expertise in a number of different areas. Talk to us today. Very important, I thought, when we reached out. She's nicely introduced already to the topic with Erland's presentation on cost effectiveness of medical devices, in this case, to treat vestibular loss. So introduce the topic a little bit generally, and then how we can think about that, how we can take that information as we're going to think about how we move forward to bring products to market. Lots of expertise. I could say all of the research and areas that she's done, but I think the last time I checked, it's like over 120 some publications. So we're in very good hands to learn about this information and how we can apply some of these techniques to the work that we're doing. They'll actually be part of the activities that happen tomorrow. Also, that doctoral candidates will work on for their project, how to apply this in a hands-on way to their specific So very excited to have you here and introduce the topic to all of us.
Well, thank you for the wonderful introduction. Yes, and thank you also for the previous presentation, because that was a nice introduction to what I was willing to tell you. This is a slide saying something about the cost of illness of vestibular loss. And this is basically what Sonia was looking for when writing the grant proposal. And already by that time, we didn't know that much about the cost of illness or the cost of treating or not treating certain conditions. And that is a problem if you want to make a point that something is important to do more research upon. So this was 2019. And then for today, I looked at newer studies, and luckily we found some studies that also included some people from this group. So I was very happy to see that. And I also noticed that Manuela Joa from Maastricht University was involved. So I have a lot of confidence in the quality of this paper. And here you see already a little bit more, because this is not only about the cost of illness, but also about the quality of life of the patient. And that is basically what it's all about. So it's not all about cost alone, but also the balance between what is important for the patient and what is the cost for society. So I will detail that a little bit more today. Now, this is some results. It's not about the details, but you can see that the yearly costs and the lifetime costs of treatment of bilateral vestibulopathy, it's not my topic, you know this, PV, are relatively high. So that means if you do something in treatment and you can improve either the quality of life side or the cost side, you add benefits to society. So that's more in general. So for today, this is the introduction. I want to make a point why health technology assessment matters. What are the key principles of economic evaluation? And then say a little bit about measuring outcomes and the qualities that was already mentioned earlier this morning. Then how do we interpret the outcomes of these types of analysis? And then a little bit about the difference between HTA in general and early HTA, which is also important when you're developing a product and want to bring it to the market. So these are the topics for today. And as Sonia already mentioned, tomorrow you will work on your deliverable, also based on the information that I give you today. So why is cost effectiveness important? I think by now it's already maybe a little bit clear, but there is an unlimited demand for resources in healthcare, and we have limited budgets. So we want to make rational choices where to spend the money, and we want to spend the money there where it gains the most benefit. And what was also already mentioned, opportunity costs matter. So if we don't treat, we can say, well, it doesn't cost us anything, so we basically are fine. But that's not true because opportunity matters. So if you don't treat, you lose. You lose quality of life, but you also lose money because people are not able to work or not to work optimally. So it's really a balance between investing and what we gain, both on the cost side and on the health side. So today I will basically talk about cost effectiveness or HTA in general. And for medical devices, most of these rules or methods are the same. But if you are really into medical device development, there is from WHO a certain regulation on how to perform economic evaluations of medical devices. And the main thing is that you study potential cost effectiveness during the development process. So even if your technology readiness level is very low, you try to look for early HTA or to see what is the headroom, what is the possibilities of my instruments. And what you always take into account is the health-related quality of life of the patient as early as possible, not as like an effect outcome, but as a possible effect. And the costs and other aspects of value. That is what the guideline advises. And if we look at the aspects of value, usually in HTA, we use the ISPOR value flower. And that is what you see here. And you see the green bullets indicate the aspects that are always included in cost effectiveness or HTA. And the dark and light blue dots or bullets are more optional or more innovative. So we basically have to look at quality of life, but if we do a more elaborate evaluation, we also are advised to look at other aspects of value. And in the decision-making process, so if it is decided to bring it to the market or not, they only look at the green dots. But if you really want to make a point that your new product has value, you can also include other aspects of this value flower from the ISPOR guidance. This is a nice slide that summarizes the most important principles of economic evaluations. And I think Mirjam van der Meulen from the UMCG, we made together a presentation for some funding organization. And this slide was based on her slide. So that's why I noticed her also. So the credits are for her for this nice slide. But if you do an economic evaluation, this is basically the scheme. So you look at a new intervention or a new product. And then you look at the cost sides of this intervention and the effect side of the intervention and the consequences. And you always compare it to the same outcomes of a comparator. So the comparator can be doing nothing. The comparator can be a placebo, or the comparator can be current care. And mostly for reimbursement decisions, the current care is the best comparator. But if you are more early in the process, it can also be doing nothing or a placebo. So this is the basic scheme, and I think you will have access to the slides tomorrow when you will be working on the deliverable. So this can be helpful to guide your thinking tomorrow. So usually when you hear people talk about cost effectiveness of an intervention, they say, oh, my intervention is cost effective. But basically, this doesn't say anything because it is cost effective compared to the comparator. So that's always something to take into account. And also when you formulate your research question, you shouldn't formulate it like, what is the cost effectiveness of my intervention? But what is the cost effectiveness of my intervention compared to standard care, for example? So you really need to specify what you want to research. yeah, well, this slide says the comparator should be realistic and a practical comparator, but in some early situations, placebo can be an option. So on the previous slide, we saw look at the costs and the effects, and the health outcomes or the effects in this equation. I will talk about a little bit now. So basically, you have three options, and in the past, we traditionally looked at health outcomes from the clinicianal side. So balance measures, maybe, or life years gained, or some aspects of hearing, blood pressure, whatever. But those are really from the clinician's perspective and do not always include what is important for the patient. So they are appealing to clinicians, so they are usually included in cost effectiveness analysis. But for the decision maker, patient reported outcomes or the patient perspective is becoming more and more important. So for cost effectiveness, we can either use a health summary score, such as Karnofsky index of the EPCAR score for babies. But more common is to use health-related quality of life, and then you can really include the patient's perspective in your final outcome, and then in the reimbursement decision, also the patient's value is included. One way and one very common way to do the cost effectiveness analysis is to look at the quality adjusted life years. So you can compare different treatment strategies or different interventions in general based on the effects and the costs. And if you look at a very clinical outcome measure, it's difficult to compare across fields. So if you want to compare, for example, interventions for problematic behavior in younger people, then you would have a different clinical outcome measure than when you have a measure against the flu, for example. And if you use QALYs, a decision maker can compare between those different fields. So it's, for a decision maker, very helpful, but maybe from the clinical side, it's a bit too global. So there's pros and cons, but the decision maker wants the QALY in order to make a decision. So the QALY basically is a combination of the quality of life of a patient and the lifetime lived in a certain study duration or a lifetime perspective. And this quality is measured on a scale from 0 to 1. So if you have optimal health or optimal health-related quality of life, your score will be 1. And the lower the score, the lower your quality of life. These utility values, they can be assessed using the Eurocall 5D instrument, but there's also other instrument. In the first paper you saw on the slide was the UI that was used for a utility instrument. I think the Eurocall 5D is the most common, but others may be more suitable for your type of research. So this Eurocall 5D, I have an example on the next slide, is kind of a health profile of a patient. And this health profile is made out of 5 domains of health with 3 or 5 levels of answering categories. So you can have a lot of possible health states. And for these health states, you can have a tariff or a value. And these values are used. So this is maybe a bit technical, so I will give a more, maybe more easy explanation. This is the instrument, the questionnaire, and you can see the 5 domains. So mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. And you can tick a box what applies to a certain person. So you can have, continue. You can make a profile for a certain health state, right? Using this instrument. So you can have someone with no mobility problems, no problems with doing self-care, but some problems with usual activities, and a moderately anxious or depressed. If you have such a health state, you have a profile, and this profile can be either optimal or very bad. And the valuation of such a profile can be done in different ways. This is the most easy, simple way, just using a visual analog scale. So if you present the profile to a member of the general public, they can indicate a certain health state, for example, the common cold with not that much problems in the 5 domains, with a health state from 0.9, for example. And a very bad health state, like a deep coma, will be close to 0, for example. Now, in theory, I said the values are between 0 and 1. And here I said 1 to -1. That's not a typo. But in theory, it was 0 to 1. But then when they were doing these valuation exercises, some people indicated that certain health states were worse than that. So if they would have to live in that health state, they would rather prefer being dead. So that's why there's also possibilities of values below 0. For example, the deep coma may be for some people be a health state that is preferred, or death may be preferred over a deep coma. So that's why that's on the slide. So the computation finally of a QALY, you have measured this utility value, this quality of life health state, and you know the lifetime that is gained with a certain intervention. So in this example, it's 10 years of life that are gained by doing a certain intervention as compared to the standard care. And then what you see here, I can better show it here, that the first 3 years were lived in a utility value of 0.75. Then the next 3.5 years, that is what you see here, 0.5, and then the last years are lived in a utility value of 0.4. So if you calculate the area under the curve, basically you have the number of QALYs lived. So over a lifetime of 10 years, here the number of QALYs gained is 5.4. So this is basically how the QALY works. So you gained 10 life years, but the QALYs are 5.4 in this example. Okay, so we talked about the cost side a little bit. We talked about health outcome side. These are 2 separate things. And in cost effectiveness analysis, we want to have a composite because we want to have one value or one measure to be able to base our decision on. So cost effectiveness analysis, the outcome basically is the composite of costs and effects. We talked already a little about the clinical outcomes. So that's the cost effectiveness and the cost utility analysis. We basically do the same, but we use the QALY in this composite of cost and outcomes. And yeah, that enables comparison between different interventions, and that is like helpful for a decision maker. So then we have our composite outcome. This is basically a point estimate, and this point estimate is usually plotted in a cost effectiveness plane. That's what you also will be doing tomorrow in your exercise. You will make some kind of a composite outcome and plot it in a cost effectiveness plane. And the cost effectiveness plane basically has the costs on the y-axis and the effectiveness on the x-axis. And then you can see the comparison between the new intervention and the comparator, so the standard care. care mostly. And your dot, your point estimate, will be in one of the 4 quadrants of this cost effectiveness plane. And usually you hope it will be here. Like your intervention is less expensive and more effective. But most of the time your intervention will be in this quadrant, so it costs a little bit more. But if your hypotheses are right, then you also gain qualities, or you gain health for the patient. So you have extra health, but also have to pay a little bit more as compared to the standard care. So here it's easy. You just implement your new intervention. Here it depends on what you are willing to pay for a certain amount of health gains. And in these 2 quadrants, usually you don't want to lose health in order to save money. So here it's usually a no. And if the intervention is more expensive and less effective, it's also, it's inferior, right? Because you pay more and you gain less. So what we are going to talk about now is the upper right quadrant. So we have more effect, but we also have to pay a little bit more. And then it basically depends on what a decision maker, like a hospital or a national reimbursement agency, wants to pay for that amount of health that you gain. And what we as researchers do is that we deliver the information of our studies to the people that decide. So we don't make a decision, we just show this is what we found. And how we show it, we show the cost effectiveness plane. But what we also do is that we make a cost effectiveness acceptability curve. And in this curve, we plot over a threshold of maximum amount of money that the decision maker may be willing to pay, the likelihood that this intervention is considered cost effectiveness, given this threshold. So this figure, the CEAC, or the cost effectiveness acceptability curve, looks like this. So if the value of the ceiling ratio is 0 in this example, this is a very positive outcome. You don't spend any extra money compared to the standard care or compared to the comparator. You already have an 80% chance that this new intervention, this hypothetical intervention, is cost effective. And the more money a decision maker is willing to pay for this additional amount of money, the higher the chance of cost effectiveness. What you mostly see in papers is that it starts at 0 and then increases to a certain maximum level. It will usually not be 100%, but yeah, so you see an increasing line and then it flattens, and then investing more is not necessary. So these plots is also what we deliver. Now, I think it was already touched upon by you that the guidelines or the willingness to pay thresholds in Europe vary widely. And some nations have quite rigid thresholds, such as the NHS. And some countries like Germany have more, the decisions are more based on negotiations. So for me as a researcher, I'm happy to be able to plot this cost effectiveness acceptability curve. So it can be interpreted from different stakeholders, basically, and they can make their own decision based on the assumptions I plotted in this graph. Yeah, and these are the willingness to pay thresholds for the Netherlands. I put this on a separate slide because our decisions are not that strict, but they're basically based on the burden of illness as well. So they take into account not the rarity of disease, as you mentioned in the previous presentation, but the burden of illness that is addressed with a certain intervention. Now, what I told until now is more general on how to perform cost effectiveness analysis. So that's called general HTA. And in early HTA, it's more a procedure that you perform during the development process of your intervention. So you can start really early when your technology is not fully developed, and you can see, for example, what is the headroom for my intervention? So what can it cost? What can be the maximum price in order for it to be cost effective? Or what should be the minimal effectiveness that I gain with my new intervention in order for it to be more cost effective? So you do different assumptions, different scenarios to see what are the elements that I need to improve or that I need to be aware of in order to have a cost-effective intervention and in order to guide my future development. So this will be more a process that you do maybe during the development of your intervention or your what you're working on, the project you're working on. So at different stages of development, and the earlier you are, the information you focus on can be more less evidence-based, but more based on assumptions and different different values. Yeah, I think this is what I told already. So at what level, what are the things I need to improve? What are the things I need to do in order to have the intervention to be cost effective? What is the room for improvement in this disease? What is the possible improvement that my intervention can reach? Yeah. So basically, this is the basic information I wanted to give today. And then I have one additional slide summarizing a little bit the basics of what I told today. But I think this is more for tomorrow. That can help you a little bit when thinking about your deliverable. So I will go to this last slide again.